welcome to our workshop. So the title is definitely how to deliver fair and understandable information to the patient concerning its treatment, I mean radiotherapy. That's the last one, sorry for that. Yeah. So I made this presentation at our annual meeting in Paris last year, and it's a big question for a physician like me to have my patient well informed and empowered before the onset of his or her treatment. So basically, my workshop will be based on 4 clinical case scenarios, taking into account the perspective of a physician like me, but also in an RT department, there are physicists, and I guess some of you are physicists, radiation technologists, and even the hospital has its point of view on the problem. So I try to put the emphasis on the many paths and pitfalls of informing the patient. What does it mean exactly? Try to give clues for daily practice, and definitely it has to be an interactive session with the audience. I see 4 speakers and 10 participants, and let us share our experience on real-life situation. So I've asked many times the organizers to send me a list of participants in order I can understand who is in front of me today. And I had no list. So if you agree, I can ask you, who are you? What is your job position? Are you working within an RT department or not? When do you have to meet the patient in person? Do you meet any patient anyway? How do you see your role in this difficult task? So please do not hesitate to participate. And if I may dare so, Madame, who are you? Okay. So I guess you see patients sometimes or never? Never. Okay. You, madam? Exactly the same. Same job? Okay. Dear speaker? So you're a chemist, right?
Yes, as I was mentioned.
And you, sir, on the last row? Okay, you never see patients. Okay, this is going to be... Sorry?
I'm still student, but I also work at hospital and the pharmacy department, so I see the patient, but the means of targeted therapy, I'm dealing with them usually after the therapy.
Yeah.
The first stage as physicians, and the last stage according to your radiation protection and so on.
Mm-hmm.
Recommendation after treatment is my part.
Okay. So the next row, sir?
Oh, hi, my name is William Barber.
Yeah.
Hi, my name is William Barber, and I'm a physicist and am giving a keynote speech tomorrow, and I am developing a cone beam single photon counting detector technology for head and neck, and
Yes.
I hope to apply that to IGRT applications.
Okay.
Previously, I developed the photon counting technology that's being implemented now in diagnostic CT.
So you do work in an RT department, actually?
Yeah, I work at UCSF and at Johns Hopkins.
Wow. You, madam?
My name is Jekaterina Sauerhoff, and I work as research coordinator in the Medical Imaging Center, and I don't see patients.
Never. Okay.
Yes, when I
Before?
radiographer, but not anymore.
Okay. Okay. So your job is diagnosis, not treatment, right? And you, madam?
My name is Juliana Simon with the University of Washington. I'm a bioengineer, but I do work some with human subjects for clinical trials.
It's clinical trials. So I won't talk about clinical trials, only current practice outside a clinical trial. Sir?
My name is Barak Zumaya. Used to monitor their dose medical radiology.
In medical radiology. So, yeah?
But now most work on management support research.
Okay. And you, madam?
My name is Handan Tanya Kuzur from Turkey. So I'm a student, so never see the patient.
You never see the patient. You're a medical student or?
Medical physicist.
Medical physicist. Okay. So one day you might work in an RT department. It might be that. It should be your future position. Dear speakers, you.
Well, I'm actually from Israel. I've been working on the development of new cells, as I reported before.
Uh-huh.
And I hope one day to see my cells used to cure cancer in patients. But so far, I only cured animals.
Not that much. Okay, it's rough. So you inform your mice, you know, the mice you treat?
Well, the mice, I treated them as nice as I could.
Okay.
No, I signed the document.
Yeah, you give them cheese. Oh.
I'm not going to cause any pain to any animal that I use for my experiment.
That's okay.
So I try to be very, very careful. I cannot talk to them,
Yeah.
but I try to be nice to them.
And you, sir?
I'm a professor of medical radiation science. So I'm an academic, so I'm an educator and a researcher. So I try to be nice to my students.
But you don't see patients. Okay. And you, sir?
So I'm a researcher, so although I work some of the time in a medical physics department, I don't
Okay.
talk to patients. I have been a patient's representative with one of the scenarios not on your list. And I would
Yeah.
agree it's a difficult task.
Yeah. Okay. So definitely, I owe you an apology. When I prepared this workshop, I thought the audience would be mainly made of medical physicists working in a radiation therapy department. So if you don't understand the clinical case scenario, don't hesitate to ask a question. I haven't gone into much details, but don't hesitate to ask me. So myself, I am a radiation oncologist. I won't repeat my resume, but my daily practice is with lung cancer patients. So I see many people with curable and rather incurable disease. And definitely the most difficult part of my job is talking to people, finding the right words for them. And I have to instantly feel what I can say, what I cannot say. Of course, there is the technical part of clinical oncology, whether it is radiation or medical, doesn't make much difference, by the way. But you have to instantly understand what you can say when you see the patient. So it's a big concern for a guy like me. It's a daily problem for me. So this is Nicolas' take, definitely, the physician's perspective. That's the clinical case scenario number one. It's the announcement consultation. So let's move to breast cancer. It's really usual practice for a radiation oncologist. This 54-year-old woman that has T1C, N1M0 left-sided breast cancer. And she has received adjuvant chemo, quite exhausting actually. And she requires post-op RT and hormonal treatment. And let's talk first about paths and pitfalls. What should we say to this lady? Does anybody has a clue? What would you tell her? You need radiation therapy, that's it. There's no discussion about it. She has to accept the treatment, that's what you told me this morning. No, she's free to say no.
No, it's your problem.
Yeah, it's my problem, yeah.
Patient
You got it right. You got it
The
right.
sick person comes to
Yeah.
you.
Yeah.
You cannot say go home if you don't want to.
No, I can't. Absolutely not. You're absolutely right. I have to convince her that's the right treatment for her, even if she's exhausted by surgery and post-op chemo, because often post-op chemo is made upfront after surgery. And RT comes only in the third position as a treatment.
No, she might consult another physician. She might say, I don't trust you, I want to hear another
Yeah.
opinion.
Yeah, sometimes it happens.
Someone and a fourth one.
Yeah.
Eventually, someone must take it.
Yes.
You as physicians cannot go home
Yeah.
if you don't
Yes.
want to.
That's an excellent intuition. If I don't perceive her to go any further with me, she can switch to another physician or back to religion, as you said earlier.
She's not allowed.
Yeah, she's not allowed. Yes, she has the right.
If she never comes to the hospital,
Yeah.
she's on her own.
Yeah.
But once she saw a physician, then it's a physician duty to make sure that she gets the best treatment
Yeah.
that the physician thinks is best for her.
Yeah.
Maybe the physician makes a mistake. Sometimes physicians make mistakes, but still they think this is the best treatment they can deliver to the patient.
But the patient might have a different perspective of how to evaluate best treatment. So I think one of the things that's very common in all of these treatments, particularly in people whose chance of survival is smaller than probably this
She has a high chance of survival.
is how you want to spend your last days.
Mhm.
And maybe somebody wouldn't want to spend their time receiving
Mhm.
radiotherapy or chemotherapy because it's going to make them feel bad. And that's their choice, isn't it?
Mhm.
But the physician took an oath that he will have any sick person that ever comes to him, he will treat them the best he can, the best way he can.
Yeah, but I'm saying that they would do.
Home is not treatment.
So, no, but you're saying, if I can be bold to interpret what you say, as that the only treatment is the one that keeps you alive,
Mhm.
not the one that gives you the best quality of life.
Mhm.
They're two different things.
Okay, she's supposed to be cured by the treatment. So it's not about quality of life, it's rather about survival.
And also under your scenario, she hasn't got an option to withdraw. She might turn around and say, I've got a free will,
Yeah,
I want to withdraw.
yeah.
So that's not the physician's responsibility.
No,
As a patient, I have a free will to
Yeah.
say, no, I
You
don't
can
want
commit
to
suicide if you want.
Uh-huh.
That's different.
But I think that's
A person comes to the physician,
Mhm.
he doesn't know what's the problem. The physician tells him, well, you have cancer. The patient is shocked by the fact that they have cancer. They go out of the clinic, shoot themselves in the
Yeah.
head, and that's it. I saw people,
Yeah.
I saw cases like that also. People just kill themselves after
Yeah.
being told.
That's a problem we have, absolutely. Shock, fear might blur judgment.
But once the patient is there, the
Mhm.
physician has to treat it.
Okay, so
That's what I think. I might be wrong.
other comments in the audience? So, definitely I picked a very simple case to show you the paradoxes of information to the patient. It might be really tricky to inform a patient like this on the balance between risk and benefit of treatment. Definitely adjuvant treatment for breast cancer, the benefit is organ preservation and more chances of survival, let's say less risk of metastatic spread. But for ladies, it's rather not clear whether they should have it or not because they're very afraid of consequences, aesthetic consequences, for instance, late sequelae. And of course, it's always difficult for us to talk about very rare and late side effects. When you irradiate on the left mama, there is the risk for myocardial infarction, maybe 7 to 15 years after radiation therapy. Should we talk about it? And it's quite rare, but it happens once in a while. And the other thing is there is this special risk of sarcoma induced by radiation. It's something like 7 to 15 patients in 10,000 cases that have to face that kind of very rare complication. Shall we talk about it? And we've tried to talk about these rare late sequelae, but the reaction of the patient is to flee and not to take the treatment, and instead of those risks, keep the risk of metastatic disease, which is, of course, a wrong choice. So it's really difficult. So the clues for me here is to insist and rephrase the benefits of treatment. Again, organ preservation, the risk reduction of metastatic spread. And you have to be empathic and let the patient talk, say its fears. It's her fears. It's really important. It's really important. So, any more comment on this medical?
So is there a formal cutoff at risk in terms of either time frame or the risk you just quoted, 15 and 10,000?
Yeah.
Is there a cutoff? Do you have to do it at 50 in 10,000 or 100 in 10,000?
No, we don't know actually. It's routine practice. From the perspective of my, medical community, let's say, it's acceptable because it is so rare. But we've tried honestly to talk about those very rare risks. For long survivors of cancer, they face those risks. But if you talk about it, people don't take the treatment. So it's not that easy to fully inform the patient on side effects.
So the risks, though, there would be immediate risk, longer risk, and then there's also a risk which is highly probable, and then there is a rare. So where do you stop on both of those two scenarios?
Well, I must say the law in my country is not very clear on that. I must say the law is quite not explicit on the level of risk you have to talk about. And we don't talk about it anymore, I must say, because we're afraid we lose more patients who will face recurrence in the breast, and in 50% of cases, recurrence in the breast comes with metastasis, and they are rarely curable. So that's one of the many paradoxes, again, of information to the patient.
One way of answering your question could be, what is the risk of, because obviously somebody who recovers from this will face many risks which they wouldn't have faced if they hadn't survived. And so if the risks from the treatment are more or less the same as the risks that you might have from having, in the average population, then it would seem that those would be risks that you could ignore in a discussion.
So where I'm coming from, I think I'm sitting in the group with back here is more on the diagnostic physics than the therapy physics. So for example, there's a radiation-induced risk for women who have screening mammography. Do we inform them of that risk? And same sort of thing for you. Do we then risk them not having their screening mammogram and not having the benefit of the diagnosis?
Yeah.
So it's a sort of similar sort of thing. But I'm hoping that most people...
That's the problem with risk and radiation. Under a certain level of exposition, it's not deterministic, it's stochastic. And here we're talking about patients who already have cancer, and they need radiation to be cured. So again, it's another paradox. It's not the standard situation where you have to irradiate the general population to make, let's say, early diagnosis or prevention, or if you see what I mean. So that's a totally different paradigm, and we don't have all the answers to the
It's
problem.
still a very similar paradigm because there's a risk versus a benefit.
But
You've got, yeah,
this patient has cancer, right?
yeah, and the benefit for them is the treatment.
It exists, of course.
The benefit from
Yeah.
where we're coming from is
We have a
the
very solid, full demonstration of the benefit. But you know, for the patient, it's not that clear.
Yes, I know.
It's not that clear.
And that's the point. So same sort of scenario I'm suggesting is where do we stop too?
Yeah,
Do we tell women who are having a
Yeah.
mammogram that you have got a 1 in 10,000 chance that you'll get breast
Yeah.
cancer 10,
Yeah.
15 years down the track?
but you come from the English-speaking part of the world, so I see the notion of risk is natural to you. And I live in the French-speaking part of the world, and the mentality here is more deterministic. It's the good treatment or not. It's more binary. That's why I have insisted so much on cultural background. You have to adapt what you say to the person in front of you. I won't present the benefits or the risk of the treatment the same way to a French patient, and sometimes I have an English patient at my consultation. I can tell you there is a big difference. The English patient will say, what are my options? What are the risks? What are the odds? There is no translation for odds ratio in France. We live in a very deterministic culture. But once the patient trusts you, she goes for it. But she has to trust you up front from day one. Sir? Sorry, I can't hear you.
Patients given information on RT before chemo or even before the operation.
So the question is?
Patients, can you hear me? Is it on? I can speak louder. So are patients in France given upfront information on radiotherapy already before chemotherapy?
Yeah, of course, of course. Often the surgeon, who is the first, let's say, actor of the treatment, operates on the patient and tells the result. You have breast cancer, this is T1, N1, you're going to need adjuvant chemo and RT, and of course, information to the patient starts here. But you know, a surgeon cannot be very specific about radiotherapy. It's not his job. It's just like a radiation oncologist talking about surgery. It's not going to be very accurate. So, of course, the patient goes through the whole treatment process, let's say, and receive many information. But what I'm saying is that I have to convince myself, my patient, for my treatment. It's very personal. And I think it's the right way to do things, but it's not that easy, even for something very ordinary. This is really basic radiation oncology with nothing special to it. Sir?
Yeah, I see this as you presented here, and I can see there is difference. For example, here breast cancer, and for example thyroid cancer. As here is you are solid as oncologist, which is basically right, and thyroid cancer, for example, solves endocrinologist in the Czech Republic. But it differs country to country. Somewhere it's endocrinology, somewhere is oncologist, and so on. Somewhere even nuclear medicine physicians and so on. And that's basically here you have to set it's like there is a treatment, and you have to describe the process and make sure that the patient understands it quite well.
Yeah.
I see the difference. So it's like it's not funny, but it's strange to me that the difference in thyroid
Mhm.
explain only something, and sometimes it's like for me as a physician, physicist, the patient asked me for my option, and I said, okay, I'm sorry, I'm not allowed to say my option. It's a physician profession, and it's their responsibility, and they have to give you the information.
Mhm.
And then there is a difference. Yeah, you have you as oncologist and our endocrinologist, but it's quite a lot of difference.
Mhm.
Right?
Of course.
I saw even, let's say, very bad examples of advancement when they're okay. It's a decision of our physician, of course, give or not to give the information about the fully state of the disease.
Mhm.
So sometimes I was, it's ethic problem, and of course it's their solution because they have to do the best for the patient. So maybe they are trying not to scare the patient, but also they are supposed to give him all the information. So sometimes it's difficult for me as a physicist.
Yeah, that's another paradox. Good information might be scary. And patients are not clients. And I often tell my patient, I'm no merchant. You're not a client, right? You're a patient. I'm a doctor. So, well, let's move to our next clinical case scenario. It should be CCS, by the way. CCS number 2. So the preparation of deep inspiration breathal radiation therapy for lung cancer. So I must explain a little bit. So to spare normal lung, we treat people in deep inspiration. They hold their breath for the time of irradiation. And we do that in 6 to 10 phases just to deliver the dose of a treatment session. So this is a technique that requires the active participation of the patient. So definitely it applies to this kind of patient, 65-year-old man, smoking, of course. T3N2 means a rather large tumor with node involvement within the mediastinum, and it's inoperable. It's in the upper right lobe of the lung. And it requires 66 gray. The gray is the unit for radiotherapy. It means 33 fractions, treatment sessions, with concurrent chemo. So here, the path and the pitfalls are more for the physicist who is, at my institution, very actively involved in the preparation of the patient. And maybe you would have a few comments on that. The patient facing a complex treatment modality. With the breath hold techniques, for instance, the patient has to wear a video Google to control his breath, to obtain a certain level of inspiration, to have his lung fully inflated, if you see what I mean. So the physicist here has to participate to the preparation. Any comments on that? If you see what I mean? Sorry for that. I should have put pictures on the example. Yeah, good question. How can we be sure he's going to make it?
Is it damaging?
Yeah, it's not damaging. He loses the advantage of being treated with a complex treatment technique. We can treat him without deep inspiration breath hold, but there's going to be more normal lung irradiated at the end of it all. So the interest of the patient is to participate and to make it, but it can be quite difficult. Sometimes, often those patients have chronic pulmonary conditions like COPD and so on. Any comments, questions, the paths and pitfalls? So, well, definitely the physicist here is involved at my institution to explain the need for video Googles during treatment, to hold breathing and spare lung, and he has to take time to just explain that. But I must say my head physicist is a scuba diver, so he's really used to hold his breath and, you know, and the patient is equipped with some sort of scuba in the mouth and video goggles to hold his breath. Of course, there is a risk of stress during treatment session, the fear of failure, not failure during treatment. The patients often feel shy about being observed and to fail. You know, it's just
They do some practice.
yeah, they need some practice before the onset of treatment. 2 or 3 sessions, blank sessions, let's say, but it works quite all right because we have some clues. So active coaching definitely is the clue here, by a physicist again. And definitely we need a friendly attitude of the RTC staff. You know, the patient has to feel like comfortable, not challenged at each and every session, you know, with angry radiation therapy technologists waiting for the treatment session to finally arrive to the end. That's the way it is. And again, make the patients visualize the benefit for him or her. That's typically empowerment. Absolutely. Any comments? Yeah?
What is the purpose of the video?
Well, the patient has a spirometer in his mouth, you know. It's just like the device you put in your mouth if you do scuba diving. Have you ever scuba dived?
Yeah.
So the patient has to inhale air just to have his lungs inflated and reach a certain level, a current level of inflation, like 1.1 liter or so. So he can see the curve of breathing within the goggles and hold his breath. And if he has to breathe again, the machine, the LINAC, stops at once. So to deliver the whole course of a treatment session, it takes 6 to 10 phases, if you see what I mean. So definitely the patient has to participate. That's interesting. That's typically the situation where the physicist is so important. Okay. No other comments, questions? So let's move to clinical case scenario number 3, how to comfort the anxious patient. So typically that's the role of the radiation therapy technologist. So that's the European word for nurses dealing with the LINAC. I don't know the word in English for that, or in England, or in Australia, or in America. RTT is, let's say, the European name of that job. So we're talking about a 73-year-old man with T2N0M0, quite curable prostate cancer, and he will require 80 gray, 40 sessions with a special technique named IMRT, intensity modulated radiotherapy, designed to lower the dose to the rectum and the bladder. And I can tell you it's pretty efficient to avoid late sequelae. Fantastic. But the patient has to come for its treatment session with a full bladder, or at least a bladder that is not empty. And I can tell you, when you are 73 and there are delays on the LINACs, sometimes it's not that easy. So the paths and pitfalls here. Any comments, any clue? Yeah. You feel concerned by prostate cancer? Yeah. Ah. This is the US, this is the French US standard of care you're talking about. 80 gray, 40 sessions. So it might be a good standard of care. But you're right, maybe we could shorten the treatment. That's a good point. But yeah, you're right. There are many studies about that. Yeah, you're right. But by reducing the number of treatment sessions, you have to increase the dose per treatment session, which exposes the patient to late sequelae. So,
Maybe in this case it's better to remove the prostate.
Oh, Life without a prostate. Mhm. There are many pitfalls. Well, I talked to you a little later on that. Yeah. So here, of course, the patient is nervous because he's an old man. He has to keep his bladder full. It's quite uncomfortable. He's anxious about the timing of his session. It's stupid as that. He's thinking of everyone has forgotten him. So we need an ID system with a barcode in the waiting room to deal with that, not to forget anybody and to reassure everyone is taken into account. And the fear to be over-irradiated. Sometimes the people get nervous about that because we had a major accident in our country 10 years ago, and it concerned prostate cancer patients. Sometimes those men count the time of their treatment session, and when the treatment session is longer, for many good reasons, by the way, for instance, imaging, just to control for the prostate position, they get nervous. My session today was not like yesterday, so it's, again, a game of reassuring the patient. And the clue here is definitely the barcode system in the waiting room. So it really helps to tame the tension, let's say, the stress, the fear to be forgotten and have to retain his urine within the bladder. And we never hesitate to show printed track records of treatment session to reassure the patient. No mistake was ever made concerning its treatment. Any clues, questions, comments? Yes, sir? Maybe, sir?
Do you have a psychologist in your care team?
Yes, we don't have as many psychologists we would need for the many prostate cancer patients we have. Sometimes we call them for very special cases, but our bet is to train the RTTs to give answer to the patient, to be reassuring, like the steward in an airplane. Sir?
Question. I'm assuming the fullness of the bladder is prostate position.
Yeah.
Do you use fiducial markers such as gold peaks in the prostate?
No, we use daily cone beam CT. Every day we check for the prostate position and the bladder not empty, full. What does this mean? Not empty. And what is in the rectum too? If there is gas and a lot of matter, we tell the patient, go to the toilet, get rid of it and come back. Yes, sir?
Yes, given the large 80 Cray dose in this treatment plan,
Mm-hmm.
and also given that you're doing daily cone beam CT,
Yeah.
are you ever concerned at all about the dose that comes from these
Yeah.
cone beam CT?
Yeah. We have to measure that precisely. We have the obligation to do so. And the dose delivered by daily cone beam CT is really negligible, less than 1/10 of a treatment session. Something like 0.2 grays. Something like 0.2 grays. It's worth it. It's worth it. It's harmless.
Yeah, I can see that it's worth it, but do you think there would be any efficacy in reducing that dose?
You mean reducing the dose to the organs?
For the cone beam CT part, just for the treatment planning part.
Oh yeah. Anything that would reduce the dose of the cone beam CT itself would be useful, but right now we have very low dose devices that allow very good imaging. Yeah?
Why don't you use brachytherapy instead of MRI?
Yeah, that's a good point. So it's due to the healthcare system. We get very good reimbursement for that. And I don't know why in France, prostate brachytherapy is really ill reimbursed. We make no money on that. That's too bad. But I told you in my talk this morning, I have to take into account the local context, the healthcare system too. I went to Canada recently. In Canada, most of patients have prostate brachytherapy because the distances are so huge in Canada. No one can go to the treatment center 40 times. So brachytherapy is really successful in Canada now. And as you know, France is rather smaller than Canada. We don't have the problem with distances. And people can even have the reimbursement of transportation to the treatment center. That's the way it is. I'm not saying it's the right way. I'm not saying the French way is the right way. I'm saying it's the context in which I work. Okay, let's move to the last one. Houston, we had a problem. So that's the hospital perspective. We made a mistake. A 44-year-old woman with a T1B and 0 M0 right-sided breast cancer was mistakenly treated for one session on the left-sided mama. What should we do? That's a big mistake. Believe it or not, it has happened at my centers maybe 7 years ago.
This also should be solved by the physicist as supervisor of the radiation.
Mm-hmm. Okay.
It should be also reported to the national committee.
Mm-hmm.
And there should be made complex, but it's gray, so it's over some limitation. I don't know the French limitation, but for example, in Czech Republic, this could be over some limitation.
Mm-hmm.
We have it's like 3 or 4 stages of the accident, and this could be like the second or third. So we should inform the patient, and we should inform the national authority, and then it should be considered what to say to the patient, because
Mm-hmm.
it's not a very high dose,
Mm-hmm.
but it potentially increase the risk of breast cancer in the let's say in the left side mama.
Mm-hmm.
I don't know. It's like 20% or something like that. It's not negligible. It's like.
But it's not that bad.
20 years.
Yeah.
It's not
Yeah.
so bad, but
No.
we have to get the information and said very sorry and.
Yeah. Yeah.
We can also be called for judgment because the patient requires some, let's say, compensation.
Excellent. Well, I'm done. Take my place. Yeah, you're absolutely right. Any other answers? Sorry, I can't hear you.
In addition, I think that staff need education.
Absolutely. Absolutely. Should we fire anybody, by the way? The guillotine for someone? No? The French way? No, we don't do that. Absolutely not. We don't use guillotine since 1981. Other comments?
I would have thought it was very important for the patient to understand that it wouldn't happen again. Not
Yeah.
for them, but
Yeah, you're right. Yeah. Absolutely. So the basic principles of informing the patient apply here too. Clear, fair, understandable. So the consequences of having just 2 gray on the wrong mama, it's not that bad. But how hard it is for a team to say it's a mistake, you know. And the physician, I think, more than the physicist, but it's my point of view, has to be involved up front, because in my context, it would be the physician that would be responsible for it all, for the mistake. So the clues never try to hide anything. Be empathic. We are sorry. We are deeply sorry. It won't happen again. Propose the patient, her case to be heard at a commission dedicated to complaints. We have that at our hospital. It's named CRUC, Commission Dedicated to Relationship with Users and Quality of Care. And definitely those kinds of mistakes are analyzed through a return on experience committee. We have to declare to the national, let's say, nuclear safety agency, named ASN in France, and so on. You're absolutely right. And again, the point here is to train people and to develop quality management to avoid this kind of mistakes to happen ever again. Other comments? Mr. Chairman? Yeah. I thank you for your attention. That's it. Oh yes, we have many procedures now. Yes. We do two things. We declare the mistakes we make internally within the hospital. Not always an accident like this, but precursors, And we analyze them through two kinds of processes. Return on the experience committee allows many things to happen, to increase the safety of treatments. But the best thing to do is something really proactive, like treatment process review. We try to anticipate what mistake could be done when a colleague has a mistake in his hands and is left alone, and how to secure practice at each and every step, when to make double checks, ID checks, for instance. We've done many things on ID checks to be sure the patient on the treatment table is the right patient and has the right treatment. At my institution, we make 53,000 treatment sessions per year, so we need to have a zero default policy. No mistake at all. It's quite difficult, I must say. Other questions? Okay, thank you.